Medical information on this site is provided as an information resource only and is not to be used or relied on for any diagnostic or treatment purposes. This information does not create any patient-physician relationship and should not be used as a substitute for professional diagnosis and treatment. Please consult your healthcare provider before making any healthcare decisions or for guidance about a specific medical condition. Doctors Ruhoy and Kaufman shall have no liability for any damages, loss, injury, or liability whatsoever suffered as a result of your reliance on the information contained in this site.
Hello, welcome to Unraveled.
Hi.
I'm Eileen Ruhoy, and I have with me my
David
colleague
Kaufman.
and friend, David Kaufman.
Hi, everyone.
We're in a state because we've been talking politics.
Yeah.
But we are happy to be here. This is Unraveled, Understanding Chronic and Complex Illness, our podcast that is now on YouTube. People still keep prescribing. It's a paraphasic error, which is actually very apropos considering our topic today of dementia, cognitive impairment. But so we're on YouTube. So please subscribe to our YouTube channel. Tell everyone, all your friends, your doctors, your kids, your family to subscribe, and stop subscribing on Patreon because I keep refunding everybody's money.
Yeah. But please keep subscribing on YouTube.
Yes,
and
please.
Get friends to subscribe.
Yes.
And doctors to subscribe.
Yes,
okay?
we want to
That's
blow
why we
up.
did this. That's why we do it and why we moved it to YouTube.
Correct. So we're going to talk about cognitive impairment and dementia today. And I think one of the reasons why we chose this topic is because I think a lot of our chronically ill patients are so concerned about their cognition because a very common complaint that we hear is that they're not thinking as well as they used to be. They used to be sharp. They're not sharp anymore. They have difficulty with word recall is very commonly heard. They have difficulty with memory, and they have a lot of brain fog. And I think that scares them a lot. And it scares me too, frankly, because some of the research in long COVID are sort of showing markers of concern of, less, healthy brain activity, for lack of a better phrase. But do you agree?
Yeah, I think it's a huge issue. I mean, I think it's important that we make some distinctions between, quote, brain fog and dementia. But there is certainly a sort of a conversational and clinical overlap between the two, and they need to be addressed. One needs to think about them both. So if a patient has brain fog, it doesn't mean they're demented, but it does mean one needs to consider, how am I going to manage that brain fog and help it reduce risk? What can be done? Part A. And Part B, what you said with long COVID, which is a whole other issue of the ongoing recognition of the immediate, medium-term, and long-term effects of long COVID on things like our brains.
Yeah, no, for sure. And there is research that supports the idea that viruses are associated with Alzheimer's disease. And the other thing is that long COVID and ME/CFS, there's research to support that there are some element of vascular involvement, which is important because we know that there's a vascular type of dementia. And in fact, there's some research that supports that Alzheimer's seems to start as a vascular concern. And when you understand the pathophysiology of things like Alzheimer's with the alpha-beta plaques, the alpha-beta peptides, and the hyperphosphorylated tau neurofibrillary tangles, it does make sense that if there isn't good vascular function, that would become more problematic. Right. So I think, and I don't want to spend a lot of time, connecting the pieces of the puzzle that I've sort of spent connecting in my brain for these patients, but I can assure you that I think it's actually concerning. And the reason why we chose to talk about this today is not because we want to scare or be fear-mongers, but there are a lot of modifiable risk factors that I think people should recognize, and they probably already know about it. It's all, with the internet these days, it's like you can't open up one of these browser home pages without some article on like brain health and sleep, for example, So I think for the most part, they're known about, but I would like to focus in on them so that whatever we can do to help our patients save their brains, I think we should do. I think it's a responsibility of all physicians to try to do that for patients, especially those who are under the throes of, again, a chronic inflammatory disease which is ME/CFS and long COVID.
Yeah, I completely agree. I mean, when you think about it in terms of the modifiable risk factors, and we'll go into detail, many or some of those are not necessarily things that your complex illness specialist might think about.
Hmm.
They may know about it, but they're focused on, SIBO and POTS and things like that. And I think it's important that we don't lose sight of these other problems. One, because they're so important. Two, they are modifiable, which is
Hmm.
really, I want to emphasize that
Yeah, they're
word,
treatable.
treatable.
Yeah.
And three, and we should discuss this, three, there is a theoretical, or there may be an increased risk in our patients, in fact, because of their chronic inflammation.
Right.
Whatever else is causing their inflammation, one of the downstream effects could be a greater risk of CNS damage or injury.
Absolutely.
So
I mean, and POTS and SIBO are good examples because we know that the brain gut axis. My brain. The the brain gut axis is super important. The metabolites that come from our microbiome actually have an effect on our brain health, and also POTS that controls vasomotor
right.
function.
I mean, you've
So,
heard me rant over and over
Mhm.
about the issue of POTS and hypoperfusion. Well,
Right.
that means less blood flow to the brain.
Yeah.
And you just finished describing the role of vascular integrity and flow in CNS injury. It's another reason we need to be aggressive about diagnosing and managing POTS.
Yeah, and there are days that when I sit and listen to patients talk about their difficulty in focus and attention and staying on track on conversation and recalling even what the conversation was about, or even when they read a book, they have to read the same paragraph over and over again, or when they're watching a movie, they don't remember what the movie was about. I often think about what we call the preclinical stage of things like Alzheimer's, and just to be fair, there are other dementia syndromes other than Alzheimer's, but it's the most common one in the world, actually. And it's, of course, the most well-known and most researched one. So I'm just going to refer to Alzheimer's, but there's obviously a lot of other dementia syndromes. But there is this preclinical stage where they aren't symptomatic, right? So when you do actual neurocognitive testing, even the MoCA or the mini mental, they score fairly well.
Right.
They don't necessarily score in a deficit where you're like, oh, clearly cognition has been affected. And that's what happens in our patients, despite the fact that they have all these concerns with regards to how their brain is functioning. And so these days you can actually order, testing of alpha beta peptides on Quest and LabCorp. It's very easy to order, and it comes as a ratio, the 42 and 40. The amyloid precursor protein it's broken down by the secretases, the beta and the gamma, and then you get the 40 amino acid alpha beta peptide, and you get the 42 amino acid alpha beta peptide. And I should point out, actually, it's not scary to have them because you should have them. They actually play a very important role in neuronal remodeling and in synaptic transmission and even neurogenesis. So, and it's specifically the 42 amino acid alpha beta peptide. So, it's important that we have it. It's just where the problem lies is when it aggregates and when it deposits. And so that's where the problem lies. And once that starts to happen, then the tau protein, which is associated with microtubules and axonal transport and homeostasis of the brain and further neuronal functioning, once the alpha beta plaques start to build, then the tau becomes hyperphosphorylated, and then you have intracellular deposition of the neurofibrillary tangles, which are made of this tau 181 specifically, which is phosphorylated. So, but you can find all of that before people are symptomatic, is my point.
Right.
Is my long-winded way of saying
No,
that.
I think that's important. I would add that if we were to run these tests routinely on our patients and they came back, quote, normal or negative, that doesn't mean that we should be any less concerned about their risk for and our responsibility to manage those risks
100%
to prevent
agree.
downstream problems.
But it might give some reassurance to the
Yes,
patients,
of course it
because
is.
most of our patients have this fear
Yes,
that
I
they're
agree.
becoming, cognitively impaired.
Right.
So yeah, I agree, and I often wonder like how far to even take the testing, because I don't want to instill fear in them. Sometimes I'll do the ApoE alleles, because the ApoE4, of course, is at greater risk of developing it, where the 3 and the 2 are not. And people tend to sort of think if they have the 3 or the 2, then it gives them at least a sense of comfort that they're not at high risk of that. So, but then I'm always afraid that we're going to find the E4s.
Yeah, it's an interesting conversation.
It
I don't know if we
is.
want to get into it, but it's really interesting. So
Yeah.
what is the value of finding out you're homozygous for ApoE4? Okay, you
Right.
learn that you have a quite significant increased risk of Alzheimer's.
Yes.
Okay, what do you
And
do
what do you
about
do
that?
now?
Yeah,
Well, then
how
maybe
do you
that's
wake up the next day?
motivation. Yeah, sorry.
How do you wake up and deal with that? And I think the way you deal with it is what we're saying and
Right.
about to say more, which is you aggressively go after the modifiable risk factors. I would argue that you don't need ApoE testing to make that decision. In the same way that I would argue if you have a high LDL cholesterol or ApoB cholesterol, you don't need a calcium CT to make a decision. If the patient says, "Oh, I'm never going to touch a statin, that's evil shit," then yeah, I would do a CT calcium to convince that patient that look at those arteries. You better do something.
Yeah.
So that's kind of how I would use ApoE. But I understand that
Interesting.
not everybody agrees with that, and
Yeah.
that there is, I don't know if it's value, there is knowledge in knowing that. I'm not sure what would I modify. I already do pretty much everything I can, so I'm not sure I'd want to know my ApoE status. I got enough problems to deal with every day when I open the newspaper,
I don't know. I'm a data junkie. I don't know. I think I want to know. I
Yeah.
mean, I've been considering testing myself.
Okay.
And you're right. What would I change? I'm not exactly sure. I
Yeah.
mean, as it is, I try to really work on modifiable risk factors. So what are they? Sleep, I think, is the number one, in my opinion. I think some of it, we can prioritize what we think is most important, and I think it's probably slightly different. But I think there's a lot of research to support the real critical role of good restorative sleep.
Right.
And we've had podcasts about sleep.
Yeah, I think we can approach this as a sort of smorgasbord or buffet of what you do, because there's a lot of things. And, look, so we'll pick sleep off the table first. Yeah, it's crucial.
Crucial.
And it's important that you did start with it because, unfortunately, that's one of the major problems in almost all of our patients. It's a defining characteristic of
Absolutely.
ME/CFS. It's a checkbox.
But even non-ME/CFS patients, I mean, sleep disorders are so prevalent in this country. Insomnia, fragmented sleep.
Right.
It's such a common complaint. I mean, I read somewhere that sleep medications are increasing in the number of prescriptions every year in this country because people just aren't sleeping. I think there's a lot of reasons for it, of course. We have technology. People are scrolling on their phones at night. I think that our culture actually doesn't prioritize sleep. And I think that's really wrong because our brains cannot function well without regular, good, restorative, rejuvenative sleep. That we know for sure.
Well, as you pointed out in a prior episode, sleep is when we, clean up. It's
Yeah.
when we do our lymphatics are doing their cleanup and their, rinse and repeat work.
Right, and that's exactly that. And during the glymphatic function is actually when there's clearance of these accumulation of these abnormal proteins, both the amyloid and the tau. And that's really important because, as I was saying, it's, the presence of these proteins is not the scary part because we need them for proper brain functioning. It's when the ratio of production and clearance is off and they get to aggregate and to accumulate and then deposit. And so we need glymphatic system to help keep that balance appropriate so there isn't the chance for aggregation.
Right.
And so, so the glymphatic system is most effective during non-REM sleep stage 3, which is, a deep state and it's a restorative state. And most patients aren't getting enough of it and certainly aren't staying in that sleep state for a long enough period of time. And so there is impaired glymphatic function, and that's a problem.
Right.
And so then you wake up and you don't feel refreshed, and it's because you still have all this debris. And it's not just the amyloid and tau, of course. It cleans out a lot of other debris and metabolic waste byproducts. But, it's a problem. You wake up, you don't feel refreshed, and, you feel like you're foggy. Every time patients, I always say, how do you feel in the morning when you wake up? And they're always like unrefreshed sleep, and they just feel like they need their coffee, that kind of thing.
Right. So another one is exercise.
Exercise.
Okay.
Oh, my gosh.
And I'm choosing that one on purpose as the number 2 because, again, that's really a challenge for our patients.
Big challenge.
And it's something I really have spent a lot of time thinking about.
Me too.
So the first issue is there's probably no other intervention as well proven as exercise to decrease the risks of the diseases of aging, which includes neurodegenerative disease.
Yes.
And I really want people to hear that. Nothing is as well proven as the role of exercise. And I don't mean going crazy and, getting your heart rate up to 180. I just mean what you have heard about, which is exercise preferably 5 to 7 days a week, moderate to intensity, doable so you don't feel collapsible when you're done.
Mm-hmm.
It has so many benefits, including dementia prevention and
Absolutely.
neurodegenerative disease, along with everything else that we could be talking about. The challenge for our patients is they can't really exercise, and it's incredibly frustrating. And I don't have a ready solution to
No,
that.
me neither. And when I talk about it, and when I was even writing about it for my book, like I was very careful in how I sort of laid it out, because I recognize that, as you said, our patients, that's a huge challenge. I mean, many of them are bedbound. Most of them are somewhat housebound. A lot of them can't be upright for long periods of time without being symptomatic. And they just don't have the energy to really engage in any, you know, meaningful kind of exercise to prevent the kind of things that
Right.
we're referring to. I still think a little bit is better than nothing. Just because you want to use your muscles, you want to get blood flow moving. It usually helps the other diagnoses of the septad that we talk about a lot. And it also just helps, I think, overall, even feeling like motivation and just outlook. And, you know, it just changes your whole affect.
Yeah, it's crucial, and a little is better than none. Um, I'll editorialize for a minute. It's one of the reasons that I try to push my patients to move faster,
Mm-hmm.
to follow up better, to do the things that we discussed doing, so that
Mm-hmm.
when I see you next time, you've done them and I can assess the results to maintain momentum. It's very frustrating for me. I know it's hard for patients if I give them 4 things to do,
Yeah.
but if you don't get down to work and really push, how are we going to get you out of bed and walking?
Right.
And the longer it takes us, the more negative that situation is, or the harder it is to get to that point. So it's a two-way street in
Mm-hmm.
terms of that. But yes, I do try to get patients to do something, to move a little bit, to walk a little bit. You know, we talk about watching your heart rate, how to
Right.
monitor it, how do you feel during, how do you feel after. Um,
I
so,
don't know. I honestly can't think of a way to simulate physical activity. I know people have tried. I realize there are all kinds of gadgets these days, but I don't know if these gadgets do any good, or if they do the same good as like true physical activity would do. What's your
yeah,
opinion
I
on
mean,
that?
I agree. You're familiar with the Neuro 20, I think it's called, that
Yes.
suit.
Yeah.
So this is like a wetsuit or whatever it's called that you wear, and it's got all these electrodes in it, and it uses low voltage
Into like
electricity to stimulate your muscles.
muscles.
And they're doing studies to see, and it's interesting. It's an idea, and we'll see. We'll see what the studies show.
Yeah. Well, my opinion, if you don't mind,
I don't mind. I just gave you an
since I
opinion.
did some neuromuscular work as a
You
neurologist.
did?
um, you know, external stimulation of muscles is not the same because it's involuntary.
Yeah.
And it's sort of like I liken it to the tilt table test, right? The whole point about the tilt table test, it removes your ability to use your muscle to
Right.
contract, to push
Same reason we do the lean test.
right,
Same idea.
exactly. Right. So, but the tilt table actually, right, but it takes away your ability to voluntarily contract your
Yeah.
muscles.
Right.
So, or involuntarily contract your muscles, because that's what you do when you stand, right? So you contract the muscles and it pushes the fluid back up through the vessels. And so on the tilt table, because you're strapped in, you don't do that. You can't do that. So that's why it's thought to be, you know, very reliable with regards to trying to sort of meet the criteria of POTS. And I know how you feel about that because I read that Masterminds thread.
One of my rants.
But so with that suit though, it's just this external involuntary,
Yeah.
or I guess, yeah, involuntary contraction of the muscles,
Right.
which is not the same as if you were to do it yourself, which would involve, by the way, your blood vessels and blood flow movement, right? And nerve involvement and nerve activation, which is not part of the Neuro 20
Yeah.
suit. I mean,
Yeah.
and I'm not trying to disparage a particular product, and so maybe we should
Yeah.
just say these kinds of things that are being designed to try to simulate exercise. And I realize that there's good intention to it, but I don't see it as the same as true physical
Right.
activity
No,
that
I
you would
totally
do.
agree. I totally agree. You know, I think our patients are limited by the whole post-exertional malaise challenge and the almost certain underlying mitochondrial dysfunction. It's
Yes.
not muscle weakness per se; it's this other phenomena.
Right. And that's another thing that I worry about with regards to electrical stimulation of muscles is that what the effect has on the
I agree.
mitochondria. So if
I
it's not
agree.
an internal drive, an internal force with the appropriate cellular functioning, like does it burden the mitochondria
Right.
even further? And I don't know the answer to that, and I'm not sure anyone does. But I think it's research that needs to happen, and it's certainly not going to happen now.
Yep.
Research is being cut
What
everywhere.
research? That sounds like DEI work. How dare you suggest
Going to get
research?
doged.
Really?
That's a word now.
Yeah, not surprised. All right.
So I don't have a great answer, but I agree with you. I always say a little bit is better than nothing, and sometimes I even will ask a patient, even while you're laying in bed or while you're sitting in a chair, can you just
Yeah,
move
exactly.
your
Lift,
legs,
lift
like
your
pass,
legs,
right?
Or even have passive exercise.
Right.
Have somebody else do it for you.
Absolutely, yeah.
It matters.
Yeah, I think it does matter, and I think again it helps, and I think the more you do it, the more you'll be able to do. It's like any exercise, right? You have to sort of get accustomed to it, and then you can build upon that. And so I have lots of conversations about movement, and I don't call it exercise necessarily because I think that's a very triggering word for because a lot of our patients were athletes, elite athletes.
I know.
Used to climb mountains and things like that. So I don't want to trigger them into sort of it's because obviously it's very upsetting that they can't do what they used to be able to do. So I try to just sort of talk about it as movement and how movement is just beneficial in general. And if you can go outdoors at all, that adds to it, right? Because then you have nature and exposure, and we know that nature exposure is one of those things that has been shown to be very beneficial. Probably more for mood and mental health than necessarily for cognition, but there's some studies that support its role in also improvement of cognition.
Right.
So sleep, movement, nutrition.
I was just going to say diet. Okay, nutrition.
Drink my blueberries, my blueberry smoothie.
Right. So there's a good example of nutrition. Right. All those lovely phenols in the blueberries are very potent. No, really, they are.
No, I know.
Yeah, you know better than me.
Are my teeth blue now?
Not yet.
Okay.
You should mix methylene blue in there.
I should actually.
Yeah.
I should make a mitochondrial smoothie. That's an idea.
We can market it.
We could market it.
Support our podcast.
We need
to. Yeah, nutrition. I mean, it's a huge deal. Again, it's challenging for our patients.
Yeah, it's very
they may have
challenging.
MCAS with trigger foods. They may have early satiety. They may have dysmotility. They may be too tired to eat. So, unfortunately, we're hitting the initial ones we're using are the ones that are most difficult for our patients. But nutrition is really key.
But they're the most important ones, right?
Yeah.
And again, that's a challenge for our patients. And which is, again, why we chose this topic, because I am worried. I'm worried about their brains, and I, that's why I think data, just knowing risk factors in terms of genetics, things that are not modifiable, like age, right? So age is the number one non-modifiable risk factor for.
I beg to differ. God damn it.
Well, none of us can control age, not just you.
Aging we can control.
We can the effects of aging we can control, but we can't control aging. I mean, you still go into
You're still
chronologically
go year by
age,
year.
right?
That's right. That's right. That's right.
So aging you can't control, and gender, right? You can't control your gender. Okay,
I'm not even allowed to say that anymore.
Oh no.
Gender? What's gender? I heard today that Arkansas is passing a law that will fine you $10,000 if you have a boy with long hair or a girl with short hair.
You're kidding.
No, heard it today.
So free to be who you are is just not allowed, is illegal now? Soon it'll be illegal to be a New Yorker.
Oh, I'm sure that's in the works. Okay. So nutrition. I don't think we should spend a ton of time on it, but I think there are some key things. Processed foods are poison. Poison. Okay? Too many carbs, poison. All right? If you eat...
Really? Too many carbs are poison?
Yeah. If you eat a lot of carbs, you alter your insulin sensitivity and insulin resistance.
What about all the studies that show the metabolites of meat breakdown are actually very toxic to the brain?
Yeah, absolutely.
Okay, so it's not just carbs.
I wasn't done.
Oh,
I wasn't going to stop at carbs. Gee whiz. And I'm trying to keep it kind of category simple, meaning
right, so
I don't
macronutrients,
want, you don't
carbs,
need to follow
fats.
a specific diet that you follow online that says 3 ounces of this and 14 grams of that.
Plus, I also think there's a lot of there isn't a consensus over the healthiest
No,
diet.
there
And I
isn't. It's a lot of
certainly,
BS.
we're not here to preach about what the right diet
Right.
is. We're just, and this is what I say to patients all the time. Like, even though, as you know, I'm vegan, have been since I'm very young, but I don't necessarily preach that to my patients. And I have a lot of patients who tell me they feel better when they eat meat. I'm not going to argue because they know their body's better than I. And so I just sort of say, but I want you to avoid processed
Yeah.
foods. I don't want you to eat a lot of sugar.
Yeah,
You
so
know,
that's what I
yeah.
say.
I mean,
Low processed, low. I do say
right,
low carb and low sugar. To me,
right.
those are the
What
three
about
biggest.
dairy?
Um, I think it should be moderate to low. It's got some nasty fats in it,
Yeah,
things that aren't good for you.
yeah,
But the challenge for our patients, as opposed theoretically for me and you, is that they need nutrition. They need sources of nutrition and protein and things like that. And sometimes their range of choices is so limited that they need to have dairy as one way to get some of that calorie and other nutrients.
right.
So it's a problem. But I don't think there's any excuse for not being able to avoid processed foods.
I completely, yeah. If you just don't buy anything that's in a
Right,
box or a bag,
right.
or cookies or donuts or ice cream.
All right, so nutrition.
Exposures, because now I'm like obsessed with this plastics thing, this
Oh yeah,
microplastics. They've,
God.
there was a study that did a bunch of brain biopsies on, from autopsies. They got a bunch of brain samples and they found all this evidence of microplastics in our brains.
Did you see? You probably didn't see the post from last night or today in Masterminds from I think it was Pete Smith.
No.
In Alzheimer's, I think it was Alzheimer's, there were 4 times as much microplastics as in
Oh my God.
non-Alzheimer's diagnosis, and that the plastics, aside from being plastic, provoke this extreme or significant inflammatory reaction. I mean, the microplastics, it's a big scary deal.
It's
Yeah,
horrifying.
it's really scary.
It's horrifying when I look around at what everyone uses, and it's all plastic.
I know and it's very hard to avoid.
Very hard to
You know,
avoid.
it's
I mean, I've gotten rid of my plastic water bottles a long time ago,
Yeah.
but I realized like my Tupperware, where I
Yeah.
bring my lunch in.
So I have just glass for the stuff
Do
you
you-
freeze.
Okay.
But what do you chop on? What do you cut on?
Right. No.
I use one of those plastic, whatever it's made
Yeah.
of. It's not wood. I used to use wood, and then I thought, well, wood's not as healthy because it leaves food remnants in the crevices.
Right. And there's.
So I went to the plastic, and now I'm reading. Oh, wait a minute! You're probably chopping plastic into your food.
Oh my God.
So it's a scary one.
Yeah. I have to test. You could test your microplastics in your blood now.
Yeah, we're doing that in our plasmapheresis
I know.
program.
Yeah, because it removes the plastic, but
Yeah.
does it get it out of the brain?
It depends on how many you do, I guess. I don't know. And yeah, so it's exposure plastics,
And other exposures, of
glyphosate,
course. Mm-hmm.
contaminants, pollution, diesel fuel, fumes. That's going to go up now because you're not
I
allowed
know.
to have an EV. So, so exposure.
Exposures. So yeah. So and then also just disease, right? So disease of aging, I guess, is what people usually call it. Though we're seeing it in young people now anyway. But things like hypertension and diabetes and other metabolic disorders.
Well, let me put that a little differently. The traditional risk factors for dementing illness or Alzheimer's are hypertension, glucose intolerance or insulin resistance, and hyperlipidemia. So those can occur at any age, and they are all 1,000% manageable and modifiable and treatable, and they will reduce risk. And the point I was trying to make a little earlier in this conversation is those are 3 things that you or I, as complex illness specialists, might not consider going after, looking for, but I'm now of the opinion that we should. And although it's stepping into primary care territory, if I find a patient with an LDL or an ApoB, let's say LDL because that's what people are familiar with, of 110, and they're 37 years old and they have septed, and I say, well, what'd your PCP say? And they will tell me, well, the PCP said, well, 110, that's not so bad. That sucks. All right, 110 is a risk factor, a significant risk factor. And I am of the school that you don't wait till you have your stroke or your heart attack or your dementia illness. You treat now to avoid it. And I feel very strongly about that. And That's true for lipids, and it's true for the insulin resistance. Hypertension is not usually a big problem in our patient population. But insulin resistance and hyperlipidemia are very big problems.
So what do you do about it?
And I think one of the arguments I would suggest, or one of the findings, is that their chronic inflammation, just as in COVID and long COVID, increases lipid and insulin resistance. So it's even more important to treat aggressively. What do I do?
Yeah.
I first go over diet.
Mm-hmm.
Again, in our patients, there's limited flexibility. I can't say exercise more because that's cruel for me to say to a patient. So I do go to drugs, and I think statins are great drugs.
I like statins.
Statins not only lower your cholesterol,
Mm-hmm.
which prevents or decreases your risk for a myriad of diseases that kill people. It reduces inflammation in blood vessels. It reduces inflammation in the endothelial lining of the
Mm-hmm.
blood vessels. It lets blood flow better. There's a reason, you're the neurologist, there's a reason that when you admit a patient with a stroke, the first thing you do, or one of the first things you do, is give them the highest possible dose of Lipitor.
Mm-hmm.
Well, you're going to try to lower their cholesterol in the middle of their stroke? No, you're not giving it for that reason. You're giving it because of its anti-inflammatory protective role.
Right.
So I would treat that very aggressively.
Right. So, I mean, I've had the experience where I've seen abnormal lipid panels, and I've actually seen elevated blood pressures that were pre-existent to even the onset of the disease that they're seeing me for. And I've even seen like frank diabetes, but also a lot of glucose intolerance. I fully admit that I'm not well versed in like treatment plans for those kinds of things. I mean, I often know like the first thing to do, like a statin, for example, but I don't know beyond that. And so I would have referred them back to their PCP to help manage these risk factors, only to then have, be told by the patient that the PCP said that it was all fine, that a hemoglobin A1C of like 5.9 is okay. And I'm like, well, that's sort of bordering on insulin resistance. Right. And so, but
it's really,
but as a specialist, I don't know where to go with it. And I'm afraid that I'm going to do something, that's not considered honestly, standard of care in the world of.
That is the problem for doctors like you and me. And, this name I keep using that we just made up, complex illness specialist, okay? I don't think we can do this work without addressing a whole wide range of things. And you're right. Most doctors, they learn one thing and they feel they can't do the other. Mm-hmm. In fact, you're learning to do and are doing many things you never learned as a neurologist. And I am doing the same things that I never learned as an internist, okay? Right. That said, I just confess to be mind-boggled and infuriated when I hear that about how a PCP will respond to a patient. And I hear it all over and over. I had a patient yesterday, an 80-year-old woman who had major short-term memory loss. This was not a complex illness type patient in the sense that she wasn't chronic fatigue or long COVID. And I won't go into why she was referred to me, but that was the reason for the referral. Why am I losing my memory? Mm-hmm. So in the context of this conversation, I looked at the labs she sent me. Her LDL was 140. What did your doctor say? Well, it's no problem. You're okay. Wow. Her A1C was 5.9. What did your doctor say? You don't really have diabetes. Nothing to do. I mean, I don't know how to say it without being really attacking, but that's just so wrong.
Yeah.
So I understand what you're saying, and maybe we need to figure out ways to help teach doctors like you who might not know that or make you comfortable with it, although it's very easy, really. But the point is, I think we don't wait for the downstream complication of these things. We intervene early to prevent those downstream complications, as long as we have interventions that are reasonable. Statins are great. They do not have a lot of side effects. They work. Metformin is great. Mm-hmm. It treats insulin resistance. It lowers glucose. It makes that curve, the glucose under the curve, lower and lower. That saves blood vessels. That saves your heart. That saves your brain. And I don't care what your underlying diagnosis is, whether it's ME/CFS, long COVID, Bartonella, or just you're a pain in the ass. You're still at risk for those things if you have those numbers, and they should be treated. End of story.
End of rant.
End of rant.
Mic drop.
Yeah.
No, it's nice to hear you say that because I mean I tend to just treat it myself, and like I said, I usually know the first things to try, but when they're not working, I sort of
So
then
talk to
I
me.
get I will. Well, I
Seriously, that's
do.
what I do when I'm going to take some crazy neuro drug that I've never used, like Keppra. What do, Eileen? I mean, you and I text back and forth
No,
all
I
week
know.
like that.
You're right, and I will start. I just sometimes I feel silly asking you those questions, like you know.
But you probably think it's silly that I don't know how to dose Keppra.
I don't think that's silly at all. That's a very specific drug. But I feel like these anyway. Yeah,
But
we
the
can go
the
on.
moral of the story here,
Yeah,
the message is, these are eminently treatable risk factors for all the things we're talking about. You can group these into the diseases of aging, which we just said are neurodegenerative, cardiovascular, and diabetes, and cancer.
hmm
And they're all treatable.
yeah,
That doesn't mean I can cure it, but it reduces risk.
right, absolutely.
And there is no excuse, I think, not to look for those risk factors and address them. If you work with a patient who's got a primary who's willing to address it, oh, that's great. That's what I'd much rather. And I always say, I don't know if I should prescribe the Crestor. I don't want to step on your PCP's toes. But if they're not going to move their toes out of the way, then
Right.
God damn it, I am going to step on them.
Yeah.
No,
I that's a great way of saying it, actually. Move your toes out of the way. I think another challenge that our patients have that research has shown contributes to cognitive impairment are things like social isolation.
Right.
Yeah. So, I spoke to a patient yesterday who basically has he's been sick for 4 years. Who he says in the last 6 months he developed tremendous anxiety, and what he was referring to as PTSD. He said because he basically lost all of his support system because everyone just, my husband always says goodwill only goes as so far, right? Which is sort of sad. There's only so much that I think family and friends can do or even feel compassion for. And so that's why I always say that those who have spouses that stick with them through it all, like just do better in the end, and whether it's because they have that emotional support or it allows them to be more motivated to sort of continue to try the crazy things that I tell them to try. I don't know exactly the reason, but if when you have support that sticks with you through thick and thin, you definitely recover and do a whole lot better in the end than when you don't. And so social isolation, I think, is a real big problem with our patients.
It's a huge problem. Luckily,
although I will say those patient groups now on social media.
That's what I was about
Oh,
to
sorry.
say. That's okay. The internet helps.
Yes.
The Facebook groups and the social media things. I mean, there's some negatives about those, but overall, I think they can be very helpful. The group of patients that I worry the most about are those who have their CNS symptoms where they have trouble with screens and they can't even use their phone.
Right.
And then they are really cut off. That is like being, put into solitary prison because you're an immigrant that you want to throw to Venezuela. Sorry.
Everything goes back to
I
politics.
can't help
with you.
it. I can't help it. I am just damaged by this.
I'm trying to live in a state of bliss.
I'm sorry. I'll stop. I'll try. Sorry.
Don't be damaged.
Let's just help so the
people.
social isolation's a big thing.
Absolutely. And so things like obesity, which I don't think is a huge problem in our patient population. I think largely because of their food restrictions, because of their MCAS. Yeah. I have patients who can only eat 4 foods, so I don't necessarily think. Although sometimes they will report weight gain due to I think some of the medications they prescribe. I think usually.
Yeah, so I think that leads me into saying let's talk about one of the 800-pound gorillas in the room, which is medications.
Pun intended.
No pun intended, right? The role or the feared role, accurate or not, of medications that you and I prescribe a lot of.
Which also can contribute, by the way, to cognitive.
That's what I'm talking about.
Oh, I thought you meant.
No, I already moved past the obesity. Okay. Sorry.
I can't keep up with you.
The concern that the H1 blockers, Benadryl and Claritin and hydroxyzine, et cetera, can lead to dementia down the road. There's all this chatter on the internet about that. Same with the benzos. I think those are the 2 biggest culprits that are attacked as causing dementia.
Yeah. So neurologists in general don't love antihistamines because there are studies that support that, but long-term use of the antihistamines and largely due to the mechanism of impairing nutrient absorption, but they also lower migraine and seizure
Wait a minute.
thresholds.
What do you mean impairing nutrient absorption?
The long-term use of antihistamines can impair nutrient absorption, which can lead to poor functioning of the brain.
How does it do that? I never heard that before.
Yeah.
That's really interesting. You mean nutrient absorption from the gut?
Mm-hmm.
Wow. Okay. I never knew that. Wow.
And again, we talked about this. The brain has H3 receptors, so and histamine is a neurotransmitter. They're histaminergic neurons.
Yeah, they're there for a reason.
Right. Absolutely.
So blocking them might be a problem.
Over a long-term use.
Right. And what I would add, which is what I say, is, it might be a problem. I'm not 100% sure, but I'll give it to you. Yes, it's a problem. I'd be concerned. All right? It's long-term. And frankly, if you're getting benefit out of your H1 blocker now so that you can function as a human being and eat food, then you shouldn't be worried about the nutrient deprivation that it might cause, because otherwise you can't eat at all.
I agree with that. I mean, I think life is full of compromises, right? You do some things for short-term purposes, and then, you work on more delayed gratification.
Right.
I agree. I mean, life is just a series of I'm going to do this now and then I'll worry about this later kind of thing. Because you need to live life. Without health, there's nothing else.
Yeah,
right?
I mean, the other way to look at it is in our patients, they're not taking these drugs electively, meaning, I think I'll just have an antihistamine today. They are taking them in order to survive, in order to control a disease process. They're not taking low-dose lorazepam, Ativan, because they want to be calm. It's because they have a disease and it helps stabilize their mast cells. And, that's the trade-off. You can either have constant MCAS mast cell degranulation, but not get demented if you make it 30 years later, or vice versa.
Right. And the thing about benzos also, it helps you sleep. So I think, again, we just talked about how important sleep is. I don't think it contributes to cognitive impairment. It's just known not to give benzos to older people who are cognitively impaired.
Oh, yes.
You avoid benzos in those kinds of scenarios. But otherwise, I don't think it's thought to cause cognitive impairment, at least.
Oh, I think there's a whole world out there that thinks that. And I'm not suggesting, and you're not suggesting, that we prescribe these things casually without thought.
No,
but
never.
There's a reason that we say, I think we should try this drug or this drug, recognizing the potential side effects and balancing those against the potential benefits.
Speaking of medications, I have just a ton of patients who have such a significant history of hypersensitivity to every medication that we've tried, even at crumbs, where I know other doctors would just think that they were insane. But I believe them because they have flare of their symptoms with just these micro dosing of just common medications.
So Larry would say that's all excipients.
Right, but I've gotten them compound. I mean, I've tried everything. But
I do too. I'm not.
Yeah, I don't know where to go. It's one of these things where then I just feel in the end.
Those are my most difficult patients.
Yeah, it's very challenging.
Yeah.
And so what do you do?
I keep trying. I do think, I'll say this with some risk, I do think that there is a small subgroup of patients, MCAS patients, who do develop a PTSD-like phenomena towards putting things in their mouth because they've had such severe reactions. And if I've discussed it with the patients, and as we talk about it, they sort of, they acknowledge that, yes, part of this is fear. And it goes to the mind-body connection, the mind-gut connection, brain plasticity. That's one of the reasons I think the brain plasticity programs can be helpful.
Yeah, for sure.
None of what I'm saying is questioning that they're not having a reaction, all right? And I want to emphasize that. I don't think they're crazy, but damn, if it were me, I'd have PTSD if I couldn't eat food. If every time I ate food, I had to worry about my heart beating fast, my brain fogging up and getting a rash, I'd be pretty goddamn scared.
I would too.
So it's a huge problem.
Yeah, it is a huge problem. I just think that it's also a huge problem that every doctor just assumes that every symptom is related to anxiety.
Yeah, definitely. That came up in my deposition today.
Did it?
Yes.
That's interesting. It just happened to my daughter. I was furious. I was really furious.
It's such a cruel and depressing default mechanism of so much of medicine. If you don't understand it, oh, you must be crazy.
It is such a weird thing, and I think it has to do with yeah, you're right. If you don't know the answer, I mean, I think doctors in general think we know a lot, and so if we don't know this, then it must be you, right? It must be your anxiety, because it can't be me, and I just don't understand. But I don't know. It's very saddening lately.
It is
to me.
I'm not going to say anything. I'm not going to go there.
Oh, that's new. Okay. So, all right, back to cognitive impairment. So, I think we're running out of time. I think that we covered a lot.
I want to say some more things.
Go, of course.
Unless Blake cuts me off.
I'm going to drink some more blueberry.
So we've gone over a lot of the risk factors and the possible remediation of those risk factors, and the fact that they may not feel relevant to the patient who has septed and can't stand up, but they are relevant.
Completely.
I want to quickly say what we didn't include was it's another reason to aggressively treat POTS. When you hypoperfuse and you have less blood flow, if it's low enough, you kill neurons.
Mm-hmm.
When you stand up and you get dizzy and lightheaded and syncopal or pre-syncopal, almost faint or faint, you can knock off some neurons. Luckily, we have trillions, and so we can knock off a lot before we're in trouble, but the goal here is knock off less. So It's a reason to be incredibly aggressive about managing and treating POTS in as fast a way as possible, which goes back to my plea for better follow-up and more momentum, okay?
Yes.
Okay, so the other thing I wanted to say is to go back to, or move it to one of my personal favorite issues, which is that my belief that the diseases of aging and the causes of those diseases, the so-called hallmarks of aging, and the medical interventions against that, GERO medicines, G-E-R-O medicines, all apply to our specific patient population. I believe, and I think there's evidence to show and prove, that the same markers that occur in the diseases of aging are occurring in our patients. And in effect, it's a sort of premature aging from chronic inflammation. And that's another reason to do everything we've just been talking about, but then to dip into the arsenal of GERO medications, GERO drugs, such as metformin, I already mentioned, rapamycin, acarbose, taurine, some of the other vitamins and amino acids, the
GLP-1.
The GLP-1 agonists, and the other one, the SGLP2. I can never get them right. The flaxins, like canagliflog. I can never say.
I know. I don't know how they name these things.
Yeah, so these drugs have been proven to decrease the inflammation, et cetera, that's leading to aging.
Yes.
And I think we should be experimenting and considering using those drugs in our patients, which is what we're doing in the rapamycin trial.
Absolutely.
And what we do with some of the other drugs like metformin. And I think it's very relevant. And I think that we're just starting to scratch the surface of that. We meaning doctors like you and I are starting to see that and learn it.
I completely agree.
And I say this as a very optimistic and encouraging statement. There's billions of dollars being put into that research, and we can use it in our patients.
I completely agree. And also, just in terms of the Alzheimer's treatments, in the last couple of years, we've had this outburst of just anti-amyloid therapies, which is sort of exciting. And again, it's why, going back to the beginning of this podcast and the conversation, I was making the point of where the production and the clearance, when that balance is off and there's too much accumulation of this amyloid stuff, which then was what causes the accumulation of the tau, we could potentially even use these therapies to try to bind them and get rid of them. And so I think there's a lot of things that we can do, but we have to be willing. One, I think we also, again, go back to the testing. I think we should test for it in our patients. It should serial test, because, and I always say that just because something was normal one year doesn't mean it's
well, I think another reason to test is to learn for research reasons. I mean, notwithstanding what I said about ApoE4, it would certainly be enlightening or interesting to see what percentage of ME/CFS patients and long COVID patients what is the percentage of of ApoE in those patients?
Yeah.
Compared to a so-called healthy population. Just like we talk about MTHFR
Right.
and what we can learn from that.
Right.
I want to just throw into the aging issue and what you just said, that's the reason that we, doctors like you and I, think plasmapheresis has benefit.
Mm-hmm.
It is basically cleaning out this stuff that accumulates. And in the anti-aging world, that's why they look at things like plasmapheresis, because it's removing all these misfolded proteins and
Right.
junky antibodies and junky junk stuff.
Junk.
Okay.
That's exactly what it
and
is.
and it's been shown to work. All right. I wish I had more evidence to prove that in our patients, but I think there's enough to have it as a treatment, one of our treatment tools, based on everything we're saying.
Absolutely, I agree completely. I mean, there are definitely improvements with the plasmapheresis. The goal is to get them to be sustained improvements, and so I've had different ideas over the last 6 months or so of ways that I can optimize the response to plasmapheresis that I've been working on with patients, and so. Yeah, I think I get excited over what the potential is for these patients and what we can do for these patients. But sometimes when it's such a challenge to get them to even try a medication, that's why I was bringing that up, because my few patients in the last couple of weeks that have been the most challenging are the ones that are either are willing to try what I prescribe, but then have these massive reactions, or the ones that are not even willing to try it because they're so afraid, which I know I'm sensitive to, and I sympathize with, and so I don't force it upon them, but it's I don't know where to go with it then.
It's huge problem.
Yeah,
when I have that, I don't know what to do.
Yeah.
Because it's okay, well then I kind of feel, I don't know, I don't say it, but I want to say, well, okay, what do you want me to do? I don't want to spend your time and your money if I can't do anything for you.
Right.
It's a horrible challenge.
I have said that.
Yeah. It's really terrible.
Yeah. Okay. Well,
probably should try to end on a happier note than that.
Yeah, I know. Well, the happy note is that we can protect your brain.
Yeah.
And there are ways that we can help, and then there are ways that you can do it on your own, right? So that's what we talked about with the risk factors that are modifiable. And there are things that patients can even do on their own for their brains. And, we also know that things like, the more education you get, which just doesn't necessarily need to be formal education, by the way. So just reading and learning, all that, use your brain.
There are podcasts out there that are wildly informative.
Oh, my gosh.
On a level that anybody can understand.
Absolutely.
Not just medical. I mean,
like ours.
Well, like ours, but yes, like ours. But others as well that will focus on, just one thing. It's so accessible, and you have you have people who do the podcaster with these incredible scientists.
Yeah.
I mean, Eric Topol has amazing podcasts.
I love his podcast.
And people on his podcast. Peter Attia, who I've learned so much from. I'm not so crazy about him in many different ways, but I love what I've learned. He has amazing people that he interviews. Some of it I could care less about. I don't give a goddamn about race cars. He does a podcast on F1 or whatever it's called. But, he interviews your neurology guy in New York, Gerald, what's his name? The guy who's at Atria? I can't remember his name. Or he'll do the insulin resistance guy that he just did, whose name is, I can't remember the name. I got brain. But I can't recommend it strongly enough.
Yeah, no, I completely agree. I learn a lot from podcasts on different topics, by the way. I don't just listen to neurology podcasts.
Oh, yeah.
I listen to lots of different, and I learn a lot. And so there are a lot of ways that you can use your brain and learn things. And research has shown that too helps to protect the brain.
I was just going to say, that's another thing for our patients specifically.
Absolutely, because it
Stay
improves
engaged.
synaptic transmission. So because you have to make those connections to learn something new. So, so there's lots of, so I think the point, of course, being is that there's a lot of things that patients can do on their own to protect their brain and modulate cognition and modulate brain function in general, which is not just cognition. The hippocampus and the temporal lobes and the amygdala is most affected in like Alzheimer's, which is behavioral and cognition, right? So there's a lot of things that can be done to improve all of that on your own, and then we help a lot. So yeah, it's and that's why it's such a partnership, by the way. And I love that about
Yep.
what we do.
I agree.
And it makes medicine fun for me again, especially neurology, because I feel like I'm their partners. And is
I
Blake like
agree.
telling us that we have to
Yeah,
go?
Blake was telling us to shut up. All right, we're going to shut
All
up.
right, we're going to shut up.
Thank you very much. Look forward to our next one, and we are moving all the Patreon episodes over to
Slowly.
YouTube. So please subscribe, and thank you.
Bye.
Bye.